Hi to everybody. So I'm just waiting for people to join in, and we'll hope to get started at 5 o'clock as planned. So there was a number of people that contacted me. Thanks, Crawford. There's a number of people that have contacted me and were wondering how they can tune in to the broadcast. And I've not done a Facebook Live event before, but my understanding was you just get a notification that I'm live, and then you can tune in and you can watch. So the plan is to start at 5 o'clock, and hopefully we'll get a number of people joining us and trying to make it sort of worthwhile as possible for you guys. I really appreciate everybody joining in. Day one of lockdown, it's been quite interesting, especially being at home. Many of you know me that I'm not at home very often, and that's what scares me most about lockdown. Is I'm going to be spending at least 3 weeks at home constantly, and I've not been at home for 3 weeks constantly for a long time. And there's a few things that have come up. One is sadly already the police have noted an increase in domestic violence, which is quite sad. But divorce lawyers anticipate an increase in divorces and a baby boom in 9 months. So let's see what happens. Okay. So I'm just getting... obviously I can't do a presentation. All you guys will see is me. Any questions and things, I have a presentation in front of me on my laptop. I've done this on my phone just because I'm upstairs in my office, which is in the loft, and I don't have the best Wi-Fi connection up here at times, so that's why I have got my laptop and my phone. Got all these people messaging me as well. So I've got a number of friends who are obviously not dentists, and they're hitting me with their jokes. It's quite funny. Where's my presentation? There we go. So yeah, we'll get started in 5 minutes. So there's a number of questions that people have sent in. I put them up on my Facebook, and I can just go through them again from my Facebook page, and I'll be covering them during or after the presentation. And these are commonly asked questions, and I'm often asked them when I'm mentoring or helping people, and people are always, quizzing me how many implants to place, maybe the mandible or maxilla. How do we decide? How do I decide on what type of prosthesis that I'm going to use as a definitive? And I've made that decision at the start. A lot of people ask about restorative space and how am I calculating it. It's not a guess. There is a technique to calculate it. How do we decide to tilt or place straight implants? Discussing AP spread and what's the minimum space required between implants. So I hope to cover these questions during the presentation. Can I just get a thumbs up that everybody can hear me? And that the picture's clear, just to let me know, because there's no other way for me to know that you can hear me. That's great. I'm getting some thumbs up coming through. Great, thanks, Alistair. I'm smiling because I'm still getting some comments from some friends that have maybe not seen me in a while, that feel like tuning in. I suppose lockdown at home, people, it's actually quite a good way to get a sort of considerable audience, because most people will be not doing much. Hi, Kev. So another couple of minutes. Everybody that's just coming in, can you just let me know that you can hear me and see me okay? But I don't plan to make this long. I'm going to try to make it succinct. My plan over the next few weeks of lockdown is to just do small bite-sized presentations on things that I find that hopefully, that you guys will find useful. I've been very fortunate in my career that I've learned from some really great clinicians, and they know who they are, and I'm very grateful for them helping me. And I just want this opportunity to maybe give a little bit back. My younger sister is tuned in. She's a lawyer. I don't know what she's going to learn by watching this video. So another minute or so, and we will make a start. So you can probably see the title is a full arch implants and the 5 keys to successful treatment planning. And these are my 5 keys. So all the information I'm giving you is my own opinion and what I've read and learnt over the years. I appreciate there are a number of ways to do this type of treatment, and all I'm doing is giving you my opinion. So bear that in mind. Before we start, I would also, this is a great textbook. It's by Saj Jivraj. He's a dental clinician, a prosthodontist based in America, but he's graduated from Manchester. He's a fantastic speaker, a very knowledgeable individual, and he has edited this book, and I really recommend it if you're keen to progress and learn more about full arch implant treatment. If you email me on my Facebook on one of the threads, then I will send you a link where you can pick this book up. Okay, and it's fantastic. It's got clinical cases, etc., etc. It's really is a worthwhile watching. Okay, so we'll make a start. So the real focus here today is treatment planning, and there's a quote by Stephen Covey, who's a fantastic author, and I think he sadly passed away. But he says all things are created twice. They're first created mentally, and then physically, and the key to creativity is to begin with the end in mind, with a vision, a blueprint of the desired result. And that is absolutely correct when it comes to full arch implant treatment. We assess our patients and we plan the treatment to the end point, to what we're trying to achieve, before we ever, pick up a scalpel or a needle, so we know exactly what we're doing. All right. So I just want to set the tone, okay, in terms of edentulosum, how big a problem it is around the world, etc. So we know from the World Health Organization there are around 300 million people in the world that have an edentulous jaw. That's an upper or a lower or both. Okay, and we also know dentures lead to a marginal improvement in quality of life, and the literature supports that if we're able to give patients an implant-supported prosthesis, we can really markedly improve their quality of life. Why do we want to restore function? Well, there's a number of reasons why we look to restore function. Primarily, there's 4 reasons. Speech, aesthetics, to improve function for the patients, and self-esteem. All right? So 4 factors, that's what we're trying to achieve for these patients. Now, I must let you know that when we're talking about a full arch, when I'm talking about full arch, I'm primarily talking about an FP3 prosthesis. As Carl Misch described in 1989, FP1, FP2 and FP3. So an FP3 prosthesis is one that has white and pink. An FP2 prosthesis is one that has long teeth. And an FP1 is direct to implant interface, and it's replacing just the tooth structure. When Misch described this classification, it also included RP4 and RP5. And the RP stands for removable prosthesis, 4 and 5. Okay, so I won't go into that too much, but it's quite useful to know the classification from Misch: FP1, FP2, FP3, RP4 and RP5. So when it comes to the 5 keys to treatment planning, I've broken them down. Firstly, I'm going to talk about identifying your patient, your ideal client. Secondly, we're going to talk about patient factors, and I break patient factors into 3 things. We're going to talk about dental, medical and social factors. Then we're going to talk about restorative and surgical points, and in between that, I'm going to talk about psychological assessment of your patient, because that's really important before we embark on this type of treatment. All right. So identifying suitable patients. What is your criteria for full arch treatment when it comes to saying to a patient, yep, you would be suitable? For me, I have a criteria. It's in my head. It's just checklists. So naturally, if patients have no teeth, then I'm able to offer them potentially full arch implant treatment. But what about your patient that has maybe 7 or 8 teeth? Or maybe they have 9 teeth, 10 teeth. How do I decide that patient's suitable for full arch treatment? Well, in my head, I have a cutoff of 5. If a patient has 5 or more teeth that I feel have a long-term good prognosis, then I will unlikely be offering them a full arch solution. So whatever it is, you know, there's often a cutoff in your mind. Well, there should be a cutoff in your mind for you to decide, should I be clearing all the patient's teeth before I provide a full arch? So whatever it is, have that in your head. And it's a good way to illustrate to patients as well, going through each individual tooth and thinking about the long-term prognosis of a tooth. And when I think about the long-term prognosis of a tooth, I'm thinking to myself, is this tooth still going to be in the patient's mouth at 5 years? Or is it likely that they're going to have had an issue with that tooth? So that's how I decide. So identifying the patient that's suitable for full arch treatment. Point 1. Second point, medical, dental and social factors. Let's talk about medical factors, which are really, really important. Let's take your diabetic patient. For my patients that come to see me that I've got diabetes, I will often ask them their HbA1c level. And if their HbA1c level, or if they don't know it, I'll ask their GP. And I'll make sure that I've optimized control. So it goes for all different types of medical conditions that patients are coming in for. More and more patients are on these weird and wonderful immunosuppressants. And I want to know the impact that those drugs are going to have on the patient's healing. So it's really, really important that we sort of build up good relationships with our fellow hospital clinicians or the patient's general practitioners to get an understanding of what their medical conditions are and how they're going to impact on healing, because that's really, really important. So that's the medical side, and that's a lecture in itself and all the fine print. But understand that patients and their medical comorbidities have an impact on their healing and implant success. And to give you an example, if we've had a patient that's had Crohn's in the past. Now, if they've got Crohn's disease, they're on some sort of immunosuppressant such as an infliximab, and sometimes these are infusions. So we will have a discussion with their physician. At what point should I be offering this patient treatment? And often I will stage treatment. So I lost you there. I'd potentially go from extractions, implants, immediate load, all in the same day. So that's from the medical side. Dental, parafunction. That's what I wanted to talk about. Patients that have parafunction habits, I am more likely not. Actually, my protocol is patients with parafunctional habit, I don't immediately load. So that's an important negative or a positive to ask patients when you're assessing them. The last one is a social. So I will make a note if patients are smokers and their alcohol intake. Smoking is a big worry for me when it comes to patients in full arch implant treatment. I will ask patients to cease smoking, and then I will not see them again for 3 months and ask them to demonstrate that they have ceased the smoking habit before I would offer treatment. It's simple. I don't have parameters where they smoke less than 5, smoke less than 10, etc., cut down. No, it's simple. For me, it needs to be black and white. They have to stop smoking for me to offer treatment. So point 1 was identifying your patient. Point 2 was patient factors. They are medical, dental, and social, and that's how I break them down. Let's look at the psychological aspect. Really, really important to analyse the psychology and the psychological state of your patient. Now, all my patients for full arch treatment get a questionnaire. I've got details. One's a PHQ-9 questionnaire. The other is an anxiety questionnaire and a dental questionnaire. And really what I'm looking to do is assess the patient's psychological readiness for treatment. Look, it's a big thing to have your teeth taken out and being given a denture potentially. And I have to make sure my patients are psychologically ready to undergo that type of treatment. The questions and if you want, I can email the questionnaire across to you. If you just drop me an email, that's not a problem. But the questionnaire asks questions like, do you feel implants last forever? Are you unhappy with your smile, etc., etc.? So and the questionnaire gives a score. But really what it is you don't sit down with the patient and go through the questionnaire. What you do is give the patient the questionnaire, let them go away with it, get it back. And then when you get it back, you can go through it, and then it highlights areas that need further discussion with the patient. It's not that one particular score will mean that you're not offering the patient treatment. It just gives you a much better idea, more information, so you know what type of patient it is that you're treating. Okay, so that is really important. So that's my third point that I would say is absolutely crucial. Now let's go into the restorative factors when it comes to full arch, and I like to break them down. And Saj Jivraj talks about it in his book. I don't know if some people missed it at the start, but this is a really, really fantastic book by Saj, Grafted Solutions for the Edentulous Patient. If you're keen, if you send me an email, I can send you a link for the book. I really recommend it. But this book highlights 7 points, and Saj talks about it a lot in his lectures, that breaking down restorative factors when we're coming to treatment planning patients. So position of the maxillary and mandibular incisal edge, restorative space, lip support, smile line, lip length, contours and emergence, tissue contact and occlusion. So there are 7 points that are when it comes to restorative diagnostic factors. So let's go to point 1. Positioning of the maxillary and mandibular incisal edge. How do we decide? Well, it's based on phonetics and aesthetics. The patient makes an F sound based on the incised edge of your centrals touching the lower lip. Now the length of your incisor is usually around 10 millimeters. The inclination is based and is assessed with giving adequate lip support. Now the lower tooth on smiling, usually you will see about 0.5 to a millimetre of the lower teeth. And then obviously your lower teeth are made to fit your upper. The restorative space that we sort of are planning really depends on the final prosthesis. Now, if it's your traditional titanium bar with an acrylic wrap, my most commonly used prosthesis that I offer patients, then I would look to have a restorative space of minimum 12 millimeters, but ideally I will always aim for 15 millimeters. Now that's your titanium bar and acrylic wrap. The other common sort of prosthesis that I sometimes will make is a whirly bridge or a mallow bridge. That's where we use a titanium bar, and it's got individualized crowns, maybe they be Emax, PMMA or composite. And there again, we're looking for a minimum restorative space from 12 to 15. And then the other material commonly used is zirconia. It's gaining much more fashion. It's becoming much more routinely available. Again, you're looking for a restorative space in the region of 15 millimeters. That is crucial when it comes. It's really important that you understand what the restorative space requirements are for the prosthesis that you're deciding to make for your patient, because one of the main long-term complications with a full arch implant treatment is prosthetic failure, and more often than not is due to lack of restorative space. And the assessment for the restorative space is made at this stage, at the treatment planning stage. Okay, so it's a really, really important point. Now, lip support, you want to assess lip support, and you want to assess that if the patient is edentulous, you want to assess that with and without a denture. And if the patient has maybe a sort of some anterior teeth missing, you want to assess that with a partial denture that has a flange and without a flange, to see if the patient's able, on their side profile, able to tolerate the lack of lip support that a flange would have. Okay, let's talk about smile line and lip length. You've got to assess the upper lip during speech, smiling, and if a patient has a full denture, you want to assess that with and without the denture. Really, really important, because what we're doing here is assessing and planning where to put our transition line. Yeah, so I want to know, when I see a patient, I will get them to smile like this. Yeah, full smile. And you can see from myself, when I smile, I've got a high smile line and I've got a wide smile. So that's really important two things, high and wide smile. If you've got a high smile, that really means that you're likely to require considerable alveoplasty to hide your transition line. Because from the point of the highest smile to hide the transition line, you need to be 3 millimeters above that. Wide smile is important, because if you're only looking to place 4 implants in the anterior zone, sometimes patients will have such a wide smile that they can see their 6s and their 7s. Then you need to look at making sure you're maximizing the AP spread with your implants. And that's where I would commonly place implants such as pterygoids. Or if a patient has adequate amount of bone, I would look to place 6 implants rather than 4, because this patient has a particularly wide smile, and I want to make sure that when they smile, there's no gaps visible, because they're going to be unhappy if when they smile they've got a gap showing. Okay, so that's the smile line and lip length, really, really important. Let's talk about contours and emergence. So the emergence profile of the final restoration should be straight as it exits from the margin. And there's a number of reasons we reduce the bone when we do full arch implant treatment. One is hide the transition line. We improve the emergence of the implant from the bone in the soft tissue, restorative space. And primarily, another reason is you want a flat surface, so your bridge is then flat or has an ovate, a fitting surface onto the soft tissue, so it's cleansable in the long term. Okay, the tissue contact to the prosthesis, you want this intaglio surface that's convex and highly polished. When I do lower full arch bridges, I will often have a metal finish, and a lot of my full arch bars are cobalt chrome, and that's because it's less, a plaque is less adherent to the cobalt chrome rather than to the acrylic. And finally, you want a good, your occlusion for your full arch. You know, you want a good AP spread of implants. You really don't want any premature contacts. You don't want any interference on lateral excursions. A light contact canine to canine, just some shim stock drag posterior to your canines. And in your interim prosthesis, you want cross arch stabilization with a screw retained prosthesis. And the interim prosthesis, you don't want any cantilevers. That's really, really, really important. And sometimes patients may be a bit taken aback if they've got a short interim prosthesis, but tell them beforehand, you know, the final's going to have an extra tooth on it, but the interim has to be this way, and you certainly don't want any cantilevers in your sort of interim bridge, which is usually just acrylic. Okay, so that's the restorative. I'll just go through them again, but note that they're highlighted in this book in a lot more detail. The 7 restorative diagnostic factors. They are positioning of your maxillary and mandibular incisal edge, restorative space, lip support, smile line and lip length, contours and emergence, tissue contact and occlusion. Okay, so that was point 4 in my 5 keys to a successful treatment planning. Now on to the final, which is the surgical evaluation. When we talk about surgical evaluation, we're talking about space, spread, and stability. So 3 S's. Space, that's your restorative space, the spread of the implants, and really importantly for me, and when my prognostic criteria for immediate load, the stability of your implants. And this is assessed primarily with your CBCT scan. So when I sort of plan, and when I'm mentoring colleagues, when I plan full arch implants, we'll get the CT scan out and we'll talk about zoning. And we'll talk about zoning of the maxilla as described by Ed Petrosian, who's a maxillofacial surgeon from America. And he talks about splitting up the maxilla into 3 zones. Zone 1, which is the anterior zone between the incisors. Zone 2, which is the premolar zone. And Zone 3, which is the molar zone. And so that's really important, because zoning and identifying where the bone is available and what zones determines what treatment options that you can offer a patient, etc. But maybe I'll discuss that in a further video in more detail, but just for the time being, note that the CBCT scan, I will assess it and classify the bone availability from looking at it and classifying it in zones 1, 2 or 3, and that will determine how I'm planning to approach this. Am I putting straight implants in? Am I putting tilted implants in? Am I putting 4 implants in? Am I putting 6 implants in, etc. What we need to be able to sort of evaluate the anatomy of the patient, and it's really, I want to know how much height and width of bone I have. Again, really important, because that determines, can I place conventional implants? I need to know, is there enough bone available for me to place implants after I carry out my planned alveoplasty, the planned alveoplasty to hide the transition line. So we talked about the maxilla. Obviously we need to know the position of the sinuses and the nasal floor, but in the mandible I want to know the position of the ID nerve and the mental foramen. Again, that will help me plan where I'm going to place my anterior and potentially the angled implants. Okay, so a recap, my 5 keys to successful treatment planning in full arch implants. Key 1 is identifying the patient. Key 2 is looking at patient factors. I've broken my patient factors into 3, is medical, dental and social. Third point was a psychological factors and psychological assessment of your patient. The fourth one is restorative factors, and that really helps you plan exactly what the prosthesis or the final prosthesis is going to look like. And then point 5 is your surgical evaluation, primarily with your CBCT and photos and smile line and planning your alveoplasty. Okay, so guys, that's it. That's the 5 keys over. Now, I'm going to go through some of the questions that I put up, but if you have any questions, please fire them out and I'll do my best to answer them and go through them. Some people have asked me about this book again. Here it is. I'll just leave it up there. Okay, so Saj Javraj, it's a BDA publication. And if you email me, I can send you a link for that book. But it really is a fantastic read and goes through some of the really important, pertinent points when it comes to full arch implants. Okay, so any questions? Everybody still hear me? I've got all these messages and... Okay. It's upside down. It's a bit late, it's over now. Mohsen's asking me cement or screw retained full arches. Always a screw retained. Always screw retained. Screw retained because it's much more retrievable. You're able to offer the patient a much more serviceable appliance, easy to screw off, put on a temporary, send it away, and then and swap up when the prosthesis is back from the lab, you can screw it back on. So absolutely, always, I think it's agreed that it's the way forward, that we should be looking to do our full arch bridges that are screw retained. Achieving passivity. Okay. Mohsen's asking me about passivity with angled implants. I think that's one for the future. I will definitely cover that in terms of how I achieve passivity as best I possibly can when I'm restoring my full arch bridges. Passivity. Okay, it's always a topic that many people ask about. Okay, so one of the questions I was asked was how many implants should be placed in each arch. Look, the literature supports, there's good evidence for 4 implants to support a full arch prosthesis. And there's loads of literature, you can look it up, loads and loads of it. High success rates with 4 implants. They can be 4 straight or 2 straight in the middle and 2 angled. It works really well. But I will always tend to place, if I can, 6 implants. Because for me, I want to minimize any cantilevers as much as possible. Because look, we know that the distal implant in a full arch prosthesis is the one that's usually in the maxilla, is the one in the most poor quality bone usually. And it is the implant that has the highest failure rate of your 4 implants. So if you have 4 implants in the maxilla, the angled or the distal implants are the most common implants to fail. Of the few numbers that you do get failures, they're the ones that are most fail. So, and often that's because there's a cantilever. If you have a cantilever, you're potentially doubling the load on these distal implants. So I will always aim to place 6 if I can. May that be 2 pterygoid implants or 2 short implants further back. In the mandible, in a mandible case, usually that's a bit trickier, but in the maxilla you usually can do something. So I always aim for 6 if I can, but look, the literature supports 4. and there's good evidence with long-term data that that's successful. Okay. I'll just answer these questions, and I'm getting some questions that I'll go through as well. What type? The most common prosthesis I use or I'll offer to my patients is a titanium bar or a cobalt chrome bar with an acrylic wrap. Few reasons. It's quite simple. It's cost effective. It's easily serviceable for the patients. Simple, and in my hands, I get good results. One of the common complaints when I speak to colleagues and people I mentor, people say chips, you get wear, etc. Yeah, absolutely, everything wears, but I never tell my patients that these appliances are indestructible. I will tell them, look, they will wear, they will discolour, and what we'll have to do is take it off after maybe about 5 years, send it to the lab, have it revised. In the interim, you'll have your temporary prosthesis in, and it'll take about a week. And then when you come back, we'll switch them over. And you know what? Patients don't mind. And that's part of my consent process. So I will tell them that. So that's the most common a prosthesis that I prescribe for my patients. It's a bar with an acrylic wrap. The second most common is a bar, a mallow bar or a whirly bridge with individualized teeth. What I tend not to do is put a bar with an acrylic wrap opposing a bar with acrylic wrap. So if I'm doing a double arch treatment for patients, I will use opposing materials, and that's because I want one to give rather than both to give. So I will use a hard with a softer one. So commonly I will use a bar with acrylic and maybe a mallow bridge with individualized teeth. The benefit with the individualized teeth is that if there's a chip or a break, you only need to take that one tooth off, and then you can either take an impression, or a lot of the time these bars are the crowns are milled and they're available, and you can just ask the lab to mill tooth 3-6. They can mill it, and you can take the old one off and put the new one on, etc. So that's it's not an issue. So it's quite good. So I think that's an important point. You should look to place opposing materials. And what Saj Jivraj talks about is his go-to is a titanium bar with acrylic opposing a zirconia. I'm pretty confident that's what he would commonly do for dual arch cases. What's the space? I've sort of earlier on in this chat, I talked about what is the space requirements for each material. It's really important to understand you're looking for 12 to 15 millimeters for most of the materials that are commonly used in full arch restorations. My go-to titanium bar with acrylic wrap, I will always aim for 15 millimeters. That's what I aim for. Is AP spread a thing that I should consider? Yeah, absolutely. As I alluded to, you want to minimise any cantilever because often that's where the issues arrive with breakages, etc. It's because of a cantilever. Is it necessary to tilt implants? Yeah, absolutely. There's a number of reasons why we tilt implants. One is anatomical, so we tilt an implant to avoid the maxillary sinus in the maxilla and to avoid the mental nerve in the mandible, so that's a reason to tilt an implant. We also tilt implant to increase our AP spread, and we also will tilt implants to increase our bone to implant contact, our BIC, and to be able to place longer implants so we can get the stability. I'll probably go into in a future Facebook Live event where we'll talk about my protocols for immediate loading that I sort of adhere by, and they're quite strict. Okay, so I'm just going to go through some questions and see if I can go that people have sent in. Any tips on? So Robbie, hi Robbie. Any tips on planning alveoplasty on CBCT, i.e. correlating clinical smile line, ideal transit with scan to decide if bone needs to be removed? Yeah, so what I do, Robbie, when it comes to planning an alveoplasty is I will get the patient to give me a full smile, something like that, so I'll make sure they've kind of really engaged these muscles levator muscles here and see exactly. And then I will measure how much gingiva is on show. And then I will reference that with the ACJ of a tooth, usually the centrals or a canine, and then I'll relate that and find a reference point on the scan, and that's how I correlate the scan to the patient's smile, and then I will draw a line, and I will draw an alveoplasty line. So, for instance, say there's 5 millimeters of gum show from my ACJ of my right canine, so 5 millimeters of gum show from the ACJ of my canine. I will go to the scan and I will draw a line from the ACJ of the canine, which should be identifiable on your scan, and I will draw a line 5 millimeters up. Then I will draw a line all across the pan view of the CBCT. So that's my alveoplasty line. Now that line is really, really important, because that line, if it goes through the sinuses, then there's a problem. Then you're not able to do FP3 prosthesis. Sorry. What I should have said is, so it's 5 millimeters. So I can see 5 millimeters of gingiva, and we know to hide the transition line for an FP3, we need to be 5 plus 3, so 8 millimeters. So sorry, I should have said on the scan from the ACJ of the canine, I'll draw a line up 8 millimeters up and then draw a line across. So that would be my planned alveoplasty. And do you know what? Sometimes you're not able to do it, and then you have to think of something else. And maybe that's an overdenture, or maybe it's an FP2 type prosthesis. So it's all these kind of things that you need to start thinking about and picking up when you're planning. Because an FP3, your traditional all-on-4 type prosthesis, isn't the answer for every patient. So it's not one technique that fits every patient. You need to be aware of other ways of managing. So I hope that helps. So that's correlating smile line. How do you translate the translation from this SI slip? Use a marker. So use markers on your scan, markers on the smile line photos and measurements, and that's how we do it. So from the highest point that you've identified that the smile line stretches up to, it's 3 millimeters above that. Okay, that adequately hides the transition line. What would you do if one of the 4 implants failed? Do you warn your all 4? They might end up with removal over denture. Okay, so obviously we need to plan for potential problems, not only immediately but in the longer term. If implants fail, absolutely, that's one guarantee I give my patients, that one or the implants will fail or the prosthesis will need replaced. I don't tell them that it's a lifetime solution for their dentition. So if an implant was to fail, then we would take it out and we would look to replace another one potentially, and then in the interim they could maybe have the prosthesis on 3 implants, or if not, then they'd be getting a denture. But I think it's hard to tell a patient if they've had a fixed prosthesis that they're then going to go on to something that's removable. So I would look for a solution that was fixed for the patient. And look, if they have 4 implants, that's why another reason why I look to place maybe 6 implants. It future plans things for these patients. What is your timeline from surgery to definitive imps? It's from Stuart. So what is your timeline from surgery? So I do my definitive impressions at 3 months. So 3 months, after 3 months of healing. Arshad's asking, what is the minimum length for all-on-4? What do you mean? Can you just clarify that, Arshad? One of the other questions I get commonly asked is, what is the ideal spacing between implants? So implants in a full arch prosthesis, there is an ideal spacing between them, and they should be in the region of a minimum of 6 millimeters, but ideally 10 millimeters of a spacing, and that's for the reason for hygiene. So if the implants are too close together, then it can be difficult to clean the prosthesis for the patients. and then obviously the long-term health of the implants. So implants and spacing is important, need to understand it. Ideally minimum 6 millimeters, but ideally I think something in the region of 10 millimeters from implant to implant is ideal. Look, I know that's not always possible. Often these are atrophic cases, but there is a minimum. Can you give clinicians advice on ridge lapping? Yep, Bill, ridge lapping is absolutely a big no-no. We try to avoid, well, actually, no ridge lapping. Please, when you're constructing your definitive restorations, make sure that they're not ridge lapped. And that's, when we're talking about ridge lapped, the undersurface of the prosthesis is curved. So it makes a prosthesis that's not cleansable for your patients. You want it to be ovate. So it's really just got one small point of contact, so patients are able to keep it clean. Okay, so Arshad says, okay, so Arshad, you're asking if you've only got 8 millimeters of bone available after alveoplasty. Okay, so that's fine because I can place short implants. Now, the only problem with having limited amount of bone, say 8 millimeters in the maxilla or mandible, is that I would then not be immediately loading on conventional implants. I would be more moving towards doing this procedure delayed. So place short implants, let it heal for 3 months, expose multi-units, and then construct the final prosthesis. So for immediate load, my minimum length of implant that I'm looking to place is 10 millimeters. And that's because the literature, all the literature is based on implants that are at least 10 millimeters in length when it comes to full arch and immediate loading. So I hope that answers. How long before the whole device? How long? Alistair's asking how long before the whole device should be replaced with a new one. Really, I haven't been doing this long enough that I've had to replace the full prosthesis. I suppose the bar and the substructure should not be replaced unless there's a fall or a breakage. But the acrylic, I would often say to the patients that you're looking at potentially having the acrylic in an acrylic prosthesis that's an FP3 revised at the kind of 5 to 7 year mark. And I've sort of told them that. And they don't get that free, they would then pay for it. Any more questions? What's your ideal splinting? Okay, Alistair's asking about, hi Alistair, asking about definitive impressions. What is your ideal splinting material? Alistair, we'll plan to do another Facebook Live event when I'll talk about restorative aspects. I don't want to go into too much now. I just want to focus on the sort of treatment planning aspect of things, but I promise I will cover that. George is saying that I've got a high smile line, yeah, and he says, I hope I don't need an FP3. If I needed one, I'd ask you to do it, George, thanks. Okay. Any more questions? I think bar usually okay, depends on patient. I hope that was useful. I'd love to hear comments. If there's anything that you would like me to cover, and then please get in touch. Just email me, drfarhanahmed@gmail.com, or drop me a message on Facebook. I'd love to hear from you, your thoughts, and if you have any further questions. If there was something that wasn't clear, then please, just drop me a message, and I'll be happy to chat you through it. Like I said, the sort of comments and what I've talked about is my opinion, my thoughts, what I've been fortunate to learn from some great people over my the journey and my career. But it's the way I do things, and I'll be frank, it works in my hands, but that doesn't mean that it'll work in your hands. But I'm pretty confident if you were to adopt this, it would, I'm pretty succinct and structured in my approach when I do full arch treatment, because I know this way works, so I don't sort of digress. Someone asked me something. What's your opinion on fully guided and bone reduction guides? I don't do full arch guided, but I've seen a number of colleagues do it. It works well, and they have good results. But I can't really comment because I've not done it. Theo, I promise I will cover passivity and how I do my best to optimize passivity when it comes to my full arch restorations. I promise to cover that in a future Facebook Live, but I don't want to keep people. I've been talking for maybe 45, 50 minutes, but I just want to focus on treatment planning, and that's all today. So to recap, when I talk about treatment planning and full arch, 5 keys. I'm talking about identifying your patient. Secondly, I talk about patient factors, which are medical, dental, and social. The third key is the psychological assessment of your patient. Fourth key is restorative, and the fifth key is surgical. Look, I am really touched that over 50, 60 people were listening in to me. I hope that you found it all really, really useful. I hope and pray that you all keep safe in these really unusual times. If you're looking for things to do or want hints and tips of things to do during this time, give me a buzz. I've got a load of things that I've planned to do to help me get through these next 3 weeks. But stay safe, look after your families, and one important thing I should say is that, in these sort of troubled times, really important to look out for each other, and especially our neighbours or people that are vulnerable in the community. Most of us are really fortunate. We have so much compared to what other people maybe don't have, and it's really important to be able to give back to people at times like this. Okay, so stay safe. I'm just going to close it. All right, thanks everybody.